St. Luke's Health System Medical Director for Primary Care. So Dr. Johnson and Dr. McGeorge will provide brief updates related to crisis standards of care activation within St. Luke's Health System, current data related to hospitalizations and capacity for care, and COVID activity in our communities. We will then open the call to give you the opportunity to ask questions. When it's time, please raise your virtual hand by clicking the button and I will call on you. When you hear your name, unmute yourself, provide your name, news organization, and your question. In the meantime, we do ask that media please be muted and turn their screens off so that we can spotlight on our speakers. You can also ask questions with the chat feature if preferred. And with that, I'll turn it over to Dr. Johnson.
Thank you. I'll start off with an update on crisis standards of care activation as requested. So our hospitals throughout St. Luke's, are operating under crisis standards of care. We're now a week into that original declaration and continue to work hard to create additional capacity to provide the care that our patients need. But it has to be recognized that our patients are not getting the same level of care that they would ordinarily expect. And there are some differences in that care. We are stretching our nursing ratios, meaning that a patient is not going to see their nurse as frequently. They're doing a lot of other tasks. We've tried to reduce the number of non-essential tasks that nurses do. I think every task a nurse does is usually essential in some way, but trying to focus their efforts on those tasks that immediately impact the direct care of their patients. We have engaged with team-based nursing strategies, bringing in some less experienced nurses from other areas where they have been working to help assist our acute care hospitals on the medical surgical floors and on our critical care units to help extend our more experienced nurses' ability to provide care. We've been asking a lot of our nurses, asking them to work extra shifts, asking them to fill in and work longer and harder, and they're getting no surprise, they're getting tired, they're worn out, and yet to their credit, they continue to step forward every day to provide great care. Our doctors are not able to provide the same level of care. We've had to delay surgeries they're essential surgeries, but they're not of immediate emergent need, and so we've had to delay those surgeries. Some cancer surgeries, for example, some of our children who have surgeries that they need to have done, just not today or tomorrow. We've had to delay those, putting a lot of stresses on our families. We've had to do that in order to create additional capacity, both by allowing the staff that has supported those surgeries to provide care for our hospitalized acute care patients and to provide some additional space, being able to move patients who need care into those spaces. As that suggests, we have also, patients need to know that they will not be getting care in the same place that they might ordinarily get care. We have opened up a number of surge units to accommodate the needs of our critical care patients as well as our medical surgical patients. That's happened across our health system. Just earlier this week, we utilized our ambulatory surgery center here just across the street from the Boise Hospital. It's connected through an underground tunnel, but it is across. We utilized that ambulatory surgery center to house our medical patients who needed care, but we didn't have a space. We've now created additional space there. And there's a number of other similar spaces across our system where patients are now receiving care that they ordinarily wouldn't have. Some additional critical care space has been created in at least 3 different locations within our system to accommodate those needs, and we continue to do that. We now have some GSA, General Services Agreement nurses who have come in to help from the federal government to help support critical care nursing. So that is a difference. So we're running as hard as we can to try to create that capacity to provide care that we need. And at least so far, we've been able to spread our resources, spread them pretty thin, but we've been able to spread them around to all of the patients who have been coming so that everyone who comes to our hospital is able to get care. We don't have to turn people away. People who need to come to the hospital, need to come to the emergency department, still need to come. We don't want people to believe that they can't get care here. Please keep coming. But we have had to reduce the level and the amount of care that we provide to anyone. One of the concerns with crisis standards of care is, of course, what if you can't provide that care to everyone? What if you do run out of your resources and can't provide that care to someone? We have processes in place to help distribute care if that gets to be the case. Of course, we first try to find other locations within our system where patients might get that care, and we've had to do that. We've moved patients around to other hospitals within our system. We've even sent patients from one of our major acute care tertiary hospitals to a critical access hospital because they had a little bit of space there. So we've had to do some things that are really different by trying to find places for those patients. In addition, if we can't find that internally, we've been calling around to our other hospitals. We've got some great state coordination to find ways to get patients to the care they need at other hospitals in our state. And so far, those processes have worked. If we continue to see increases in our patients, then we may get to the point where we have to utilize our state's plan to allocate resources. We have more people who need care than what we can provide, can't find other locations. Then there is the possibility in the future here that we would have to not provide care to someone who otherwise might need that care. We certainly are doing everything we can to try and prevent that possibility, but it is still a possibility. So that would be my update. Thank you.
Thank you, Dr. Johnson. And then Dr. McGeorge, would you like to provide some comments?
Yes, thank you. So just one more comment on the crisis standards, and then I want to talk about a couple of other things. I think, it's really important for people to understand that the care being provided is not the standard of care to which we have been accustomed for a long time. And it's really like a peanut butter spread of reducing support for our patients as we're spreading our resources more and more thin. So really everybody needing health care right now is taking part of the share of that diminished resource. So I just wanted to emphasize that also. I want to talk a little bit about just a couple of updates here so one is on the vaccine boosters. A lot of people, we're having a lot of interest, a lot of questions, even from our own doctors saying, when can I get my third vaccine? And just want to provide an update and a little bit of context here and some clarification on a very confusing, muddy process here. So about a month ago, it might have been 2 months ago, the FDA approved and the CDC endorsed getting a third vaccine for people who were immunocompromised. So that would be people who maybe are actively undergoing chemotherapy or an organ transplant patient, people that immune systems were known to have not reacted as well to the vaccine as they should have. So that already was approved a little while back. That third vaccine applies to both Moderna and Pfizer and is 1 month after the booster. So really for those people in that category, it's the first dose, which we call the primer. Then what we used to call the booster was 3 to 4 weeks, depending. And now for those people, they could wait another 4 weeks and actually get a third vaccine. So that's already been approved. That's been in the works, and we are already providing that. Patients just need to attest that they meet those criteria of being immunocompromised. What is new, though, and what is new this week, and I think many of us saw that the FDA did approve emergency use authorization for a third vaccine of the Pfizer vaccine for certain people of a little bit higher risk, but not as high as like the organ transplant patient list. And so these are more people age 65 and up, people who have a severe risk of COVID if they were to get it. So that would be like someone who's obese, someone who's diabetic, or maybe is immune compromised, but not as severely. And then they also, FDA, again, approved this third vaccine for people who are working in an institution or an occupation that would put them at increased risk for getting COVID. So this kind of goes back to like healthcare workers, police officers, teachers, that group. So there are a couple of things to keep in mind. One is that is the FDA clearance, the EUA. However, the CDC and also something called the ACIP, a lot of acronyms, but the ACIP is the Advisory Committee on Immunization Practices, and they really work with the CDC as the authority on vaccines, and they're meeting, they should be meeting today, and we should hear today or tomorrow whether, what the CDC is ultimately going to recommend. It is that recommendation that healthcare providers follow. So things to keep in mind, it's really complicated for a couple of reasons. One is this is only going to be for Pfizer recipients. So for someone who is a healthcare worker or age 70 and received Moderna, it is not likely that this new recommendation is going to affect you. We are expecting more recommendations down the road regarding the Johnson & Johnson and the Moderna, but are not anticipating any new recommendations in the next few days on those. Additionally, what's different from this guideline is that this would be 6 months after your booster, not 1 month. So you can see it's getting kind of muddied and confusing for people of when they should get their next vaccine and who can get it. The other thing is there is emerging data that Moderna, historically, those that have received Moderna might be slightly more protected against the Delta variant. So that might be another reason why those that receive Moderna, can feel comfortable waiting. It is not, there is no emergency for people to run out and get this third dose. I know a lot of people are very excited to get the third dose, but there's not this emergent rush for everybody to get it on Monday if it's available as early as Monday. So just want people to keep that in mind. Next, just briefly want to talk about monoclonal antibody therapy. And then just one other quick topic is other things that we really are asking the public to think about. So monoclonal antibodies are, again, if you think about it, they are really synthetic antibodies that are given to someone at the very beginning of their COVID infection if they are at moderate to severe risk of hospitalization. We know that people at the absolute highest risk are people who are obese or diabetic, third trimester of pregnancy, if they're severely immunocompromised. Again, let's go back to the organ transplant examples, very high risk for getting hospitalized. We also know people who have not been vaccinated are at higher risk of being hospitalized. So those people especially, we want to make sure they get the monoclonal antibodies. But there are a lot of other people who fit criteria, and we also, as supplies allow, we will continue to treat everybody who fits criteria. And those criteria can be even just being mildly overweight or having high blood pressure. It doesn't take much to be at increased risk for hospitalization from COVID. And of course, as you've seen, there are patients, you've seen this in the news, just saw it earlier this week, people that are very healthy otherwise and are getting COVID or getting severe COVID. So next, just to talk about other actions, just for people to really think about. One is, I cannot emphasize enough how important it is for pregnant women, pregnant people to get vaccinated. I think I saw recently about 30% of pregnant patients are vaccinated in the US, and that is just not enough. We are seeing really severe cases of COVID in pregnant women. And when that happens, it's just, it puts the mom at risk, it puts the baby at risk, and obviously it would be terribly devastating to the family when they lose either the mom or the baby. So please, if you're pregnant, do get vaccinated. The American College of Obstetricians and Gynecologists, as well as the CDC, strongly recommend you get vaccinated. Remember, now's the time to get flu shots. Do get your flu shot. Yes, you can get flu shot and COVID vaccine on the same day. Do mask. Again, we know that is the best thing that's going to work today. If you today decide to start getting vaccinated, that is wonderful. But do keep in mind that it really is 2 weeks after your second vaccine that you're fully vaccinated. So that's going to take a while. So especially during this surge and crisis, please do everything you can to avoid getting COVID. Avoid indoor gatherings. Don't go to the emergency room or the urgent care for COVID testing. We're just really overwhelmed. And then the last thing I would just ask people, I'm thinking back about last summer and last spring, so say 18 months ago. And remember, we used to see all these signs, heroes work here, healthcare workers are amazing, all these different things. And we're still seeing that, and that's wonderful, but we're also seeing a lot of people being less generous to their neighbors and friends that are healthcare workers. And so really supporting our healthcare workers, they're going through a lot right now, and anything that we can do to show our support for their physical and emotional exhaustion would be really, really appreciated by all of them, I'm sure. So thank you.
Thank you, Dr. McGeorge. And now we will open it up for questions from the media. And again, I ask that you raise your virtual hand. I will call on you, and if you can state your organization and your question, and if you are directing your question to either Dr. McGeorge or Dr. Johnson. Again, Melissa Davlin, please go ahead.
Thanks. This is Melissa Davlin with Idaho Reports on Public Television. I was wondering if anyone on the call could maybe give some insight into the cost for patients and their families who are being transported to other facilities, who are in the ICU for 3 or 4 weeks, when we're talking about a free vaccine versus the medical bills they might be receiving after the end of their treatments.
Oh, you're on mute, I think, Frank. Sorry, Dr. Johnson, sorry.
I appreciate it. I can take a stab at that, Dr. McGeorge. Thanks. I mean, the cost is high. I can't quote specific dollar figures or numbers, but certainly intensive care unit care is incredibly expensive. And hospitalizations are long, oftentimes with COVID. We sometimes will see patients in the hospital for weeks, sometimes over a month, as they are being treated for COVID in the intensive care unit often. So very expensive. The cost of transport between hospitals is a little bit less clear. I don't know that I could speak specifically to that, but yeah, high cost. And I would point out the cost after COVID. Patients who have been hospitalized with COVID, it's not like you get out of the hospital and you jump back to your normal life. There is a long, long recovery, and the damage that's done to people's lungs following a prolonged and severe case of COVID is really significant. There's people who are disabled following recovery of COVID, and they may be disabled for the rest of their life because the lung damage is caused by COVID. Huge cost for that, not only in an individual basis, but a huge cost to our state as well, with increased in the cost to our Medicaid budget. People on disability will be covered by Medicaid, and so there's a cost to our state and our general public as well.
And Joy, if I could follow up on that too, I wanted, and when Dr. Johnson mentioned before, we're used to using the word critical access hospital. That's a rural hospital that's very small. And so what we're talking about, some of these transfers are transferring patients from the emergency room from a higher level hospital to where there's actually a bed, and it could be in a rural hospital in Idaho. So there's obvious costs there. A couple of other examples of costs for people to think about too is, as Dr. Johnson alluded to, the long hauler COVID. We have seen people that are really severely disabled after having had COVID-19. And so that is a cost, to them, obviously, whether they are severely disabled or if they die. The financial devastation to the family when that's the breadwinner of the family, we're seeing a lot of that happening too. So those are just other things to think about.
Thank you both. And next we have Zachary Bruhl. Go ahead, Zachary.
Good afternoon, doctors. Thank you so much for your time today. I'm Zach Bruhl with KMVT News out of Twin Falls. A quick question for Dr. McGeorge. You talked about the waters being so muddied around those third shots, those booster shots. It's kind of difficult for people to understand when they qualify, if they qualify. What would you advise people to help them figure out? It's just a conversation with your doctor. Is there a website you can visit to help you realize your qualifications?
Yeah, that's a great one. So I think, yes, first you can always ask your primary care physician or primary care provider for help with that. I know at St. Luke's, what we do is we try to build things into our software that kind of help if you're trying to schedule it. It asks you questions and kind of steers you in the direction of whether it's appropriate now to get tested. We do try to post information on our website, and we can continue to try to hone that and provide information. I can tell you it is going to be hard because even some of our providers right now are trying to think through, Moderna, Pfizer, and, even to make it even more complicated is when we first rolled out the vaccines, many of our healthcare workers got Pfizer up in a rural area, but now we only have Moderna up there, for example. So there's just a lot of operational things that have to take place. It's going to be complicated for us. We're up to it. We're hopefully rising to the challenge here. But I think people need to have patience. And again, the pharmacies too, their pharmacists probably could help them and let them know or answer some of these questions for them too. But again, just want to emphasize, it's not like a mad rush that if today we find out it is actually approved, it's actually not a mad rush. And in fact, the ACIP is still going to update the patient information forms and things like that. So it still will take a few days, and I anticipate it'll more likely be next week before we're really planning on giving those vaccines to that new wave of people. And again, remember, it's probably only going to be Pfizer, and it's going to be 6 months, whereas the one for the immunocompromised is 1 month, and it's Pfizer or Moderna. So we'll just continue to keep you updated.
Yeah, they certainly do keep us on our toes, don't they?
Yeah.
Thank you. And next we have Tristan Lewis from KTVB.
Hi there. I was wondering if either of you can just elaborate more on just the partnerships you guys have with local groups around the community to get more people vaccinated. I mean, there's a lot of people that might still not know all the facts about the vaccines, or there's people with vaccine hesitancy. Is there a lot more partnerships you guys have come up with within the past several weeks, just especially with crisis standards of care issued?
Do you want me to?
Yeah.
Dr. Johnson. So yes, so I know St. Luke's is part of a collaborative with other organizations. So the Idaho Department of Health and Welfare is on that collaborative. The VA, St. Alphonsus is on that, where we are trying to provide ways to reach into the community and help. We always are willing to partner wherever anyone wants or needs help with a clinical resource to help answer questions. We're always happy to do that and would offer that up. But yes, we are working with other community partners.
Great, thank you. And next we have Derek Hawkins. Derek, go ahead.
Hi there, Derek Hawkins of the Washington Post. How close?
Hey, Derek, we're having a hard time hearing you. Can you speak up a little bit?
Sure. Is that any better?
It sure is.
Okay, good. Sorry, Derek Hawkins from the Washington Post. How close are you guys to exceeding capacity in your morgues? And as the death toll from this surge continues to rise, how do you plan to handle that? This is obviously something that's very kind of disturbing, to families of these victims if they're stored in these freezer trucks and this sort of thing.
Yeah, I can take that on. We have exceeded more capacity in some of our facilities, and we've been thankfully able to work with our county coroner's offices to help address that situation. So already at and above capacity, working with local county coroner's offices to help provide for additional support for morgue is the way we've addressed that. So far, we've been able to be successful at that. Yeah, it's a terrible situation. At least, oftentimes in our hospitals across the system, 5, 6, 7, 8 deaths every day. So that's it does put a strain on that.
Great, thank you. And next we have Ian Stevenson from Idaho Statesman. Ian, please go ahead.
Thanks. Dr. Johnson, before when you were talking about some of the issues that have been leading to this crisis situation at your facilities, you mentioned not having enough ICU or regular hospital beds and not having enough nurses or other staffing to give people sort of the expected care that they're used to. Are there other problems or shortages looming that may also cause need to allocate care to certain people, like perhaps ventilators or other equipment shortages?
Mm-hmm. Yeah, so those are all things that we keep close track on, and we've got a great supply chain team that tries to keep up our supply. But yeah, there's going to be a limit at some point. Supplying oxygen to patients is, of course, one of those things that's a risk. As of this morning, we were using 77 out of our 101 ventilators, which sounds like we have a lot, but those additional 25 ventilators are some of the ones that are not traditionally used for adults in ICU level care. They can work. We can make them work, but it's not the usual. We have worked to secure an additional 20 or 25 ventilators. They're tough to come by these days. There's lots of delays because everyone is doing the same thing, but we were able to secure those. Same thing with a device called BiPAP. BiPAP is a positive pressure mask that helps facilitate oxygen delivery, and we're keeping a close eye on that. We've had hospitals in our system that have run right up to the brink, and we've had to move those BiPAP devices around to maintain our ability to provide that kind of oxygen treatment. Other supplies that we keep an eye out on, oxygen delivery itself. We are facing the situation in some of our hospitals, our big hospitals, where the building itself isn't designed to allow for the administration of all the oxygen that's coming through the walls, through pipes and tubes to patients, and we're running into a limit on that. Here in the Boise Hospital, we're working to expand our intensive care unit capacity, but we're going to hit a limit where we just can't pump any more oxygen into those rooms. So yes, there are some limits in oxygen delivery that we haven't yet faced. We're pushing up against the brink, and we're working hard to try to address that. But if this surge keeps going high, we will hit a limit where we can't provide that service any longer.
Okay, thank you, Dr. Johnson. Next, we have Joe Paris from KTVB.
Thanks for your time. Appreciate it. It's been 1 week since crisis standards of care were activated statewide, and I'm curious, from what you're seeing in the St. Luke's health system, have things gotten better, worse, or stayed the same over the last week?
I've got an answer for that if you want, Dr. McGeorge, and you can fill in. Today, we hit a new high for hospitalized COVID patients in our system. We were at 315 hospitalized COVID patients. That's worse. Back at the end of July, we had 30 patients hospitalized with COVID. So in a really short period of time, we've had a tenfold increase. That's worse. Our ICU capacity is at all-time highs, and we've added additional space to those surge ICU beds. That's worse. Our numbers of deaths from COVID continue to rise. So we're worse.
I think the only thing that's better is it has really given us the opportunity to kind of think through and continue to be more creative in ways to, spread out care as much as we can to help as many people as we can. And so, another example of that is things like things we would have mild cases of COVID where they need oxygen, where we would have admitted them to the hospital. That's not mild. I don't mean that's actually severe, but it's really allowed us to continue to take care of more patients by not quite providing the level of care historically that we would have still providing as good care as we can, but recognizing that we need to do things a little differently.
Okay, thank you. And next we have Rachel Cohen from Boise State Radio. Rachel, I see that you are not muted, but we can't hear you. Okay, Rachel, you are muted now, but if you're having trouble, you could also type your question in the chat and we'll be happy to read it for you. In the meantime, I'll move on to Nicole and get back to Rachel. Nicole Camarda, go ahead with your question.
Hi, this is Nicole Camarda with Idaho News 6. We've been talking a lot about healthcare staff, and we learned last week that St. Luke's and St. Alphonsus both put a pause on the vaccine requirement for employees. And I'm wondering if this has, helped at all, if there have been staff who's been redeployed to kind of help on the front lines, or what this has looked like over the last few days since putting this pause on.
Do you want to, or do you want
I can take that if you like. I would answer that we have not put a pause on our vaccine requirement. We have put a delay on any corrective action that would be a result of that, but we still have a requirement for COVID vaccination. That is super important. Almost all of our patients, 98% of our hospitalized patients are unvaccinated. Our deaths that we're seeing from COVID are in unvaccinated patients, not 100%, but pretty close. Those it's hard on our teams. Our teams are seeing that and they're saying, man, this crisis, this death, this disease in our hospitals is for the most part unnecessary because vaccinations work. So our teams are seeing that and we know that. So the vaccine requirement continues to be in place, but enforcement of any corrective action has been delayed. It's crisis standards of staffing. We need those staff right now, regardless of their compliance with the vaccine requirement, and so we're allowing them to continue to work with some additional safety measures in place.
I would add, so that's exactly right. One other thing is, we are seeing, I don't know the numbers, but we are seeing some employees who actually have asked to rescind their request for accommodation and have decided to get vaccinated. I just had one that came across my email today who was doing that. We've seen employees who with pregnancy are not required to get it, although strongly encouraged, and also too are now having second thoughts and choosing to get vaccinated.
Okay, thank you. And I'll read Nicole Camarda's question. Her question is there anything in our numbers that tells us when we might reach a peak in COVID hospitalizations?
Do you want me to take? I have a couple of thoughts there, Frank.
I'll defer to you, Dr. Yeah.
We didn't plan this well. Obviously, we're winging it here. But so a couple of things. I don't know. It's always hard to know what's going to happen. We know that first, with each of these surges, you start to see it go up in the community. Then you start to see it happen in the hospital. Then you start to see the ICUs fill up. Then you start to see the deaths. And that's the trend of how it goes. And that's the timing of just how COVID works. So this week compared to last week, I have noticed a slight decrease in the percent positives of patients that were of our symptomatic patients we're seeing who are coming in for COVID testing. That number was extraordinarily high last week. It was in the mid-30s, which is extraordinarily high. The CDC, considers significant community spread over 5% of tests positive. So extraordinarily high. I did this week when I looked, that was slightly down. The other thing slightly down is our urgent care volumes. Again, I don't know if this is just a little blip now that we've got other things going on in the community that can continue to spread COVID, or if we are just starting to see the beginning of things changing, and we won't know for a couple of weeks if that's meaningful or not.
Yeah, I'd point out a couple of other things as well. The Boise City wastewater treatment plant measures COVID volumes, and I'm told, I haven't confirmed this independently, but I'm told that their numbers are slightly down in terms of COVID in wastewater. That's a good sign. Our vaccination rates are creeping up. Kudos to those citizens who've stepped up and got vaccinated. That's a big step. So that's some reason for optimism as well. And then I'm told, I haven't confirmed this independently, but it's been shared that the test positivity rate has also been going down, which is another marker, as Dr. McGeorge points out, for possible slowing of this surge. Thanks.
Thank you. We all look for those bright spots. And my apologies, that was not Nicole's question, that was Rachel Cohen's question. And next we have Andrew Barrettline. Andrew, go ahead.
Hey, thank you for your time, Andrew with Channel 7. You mentioned that, vaccination rates are going up a little bit, test positive rates are going down a little bit, but there are people that just do not want to get vaccinated. Are monoclonal antibodies the best thing we have? Because there are people that just are not willing to budge, and we can continue to report what we're being told by experts, but there are people that just won't listen. So are monoclonal antibodies the solution, I guess? Is that what we have?
No, so monoclonal antibodies. So first of all, monoclonal antibodies are synthetic. So it's just kind of hard to imagine that feels okay compared with a vaccine. But a couple things about monoclonal antibodies. One is there's a limited supply, and I'm very concerned. We've been kind of touch and go with our supply, but we've had enough. But I'm concerned about that, and you may be following that nationally, that there is concern about having enough monoclonal antibody. So that's one. Two is, what I would say is, to me, it's kind of like a car accident. And I heard this analogy somewhere, and I really love it, is, the best thing to do is to be a defensive driver, don't drink and drive, all the things we know to avoid having a car accident. So preventing that car accident is the best thing. Once you have your car accident, yeah, you're better off if you have airbags to kind of blunt the damage from the accident, but it's always far better to prevent it. And as I said earlier this week to a few people, of all times, now is not the time to get COVID. That getting COVID now compared to getting COVID in this past spring is a different can of worms. We're seeing higher mortality, probably, some of that may be Delta variant, we don't know, or if it's frankly that there are fewer nurses to take care of our patients, that we have higher, patient to nursing ratios. So it is just really a bad time to get COVID. So everything you can to prevent the car accident now is really the best thing to do. And then, yes, if you're very early in your diagnosis and you're at high risk for hospitalization, absolutely, we want you to get the monoclonal antibodies.
Okay, thank you. And then we have another question from Melissa Davlin. Melissa, go ahead.
Thank you. I've been watching the numbers on the IDHW dashboard where pediatric hospitalizations are slowly creeping up. And that, I know that doesn't necessarily mean pediatric ICU admissions, but can either of you give us any insight into what kind of pediatrics you're seeing end up actually admitted to the hospital? Are they younger? Are they teenagers? Is there a range? What's their condition?
Yeah, I can answer that question. So as of this morning, we had 5 pediatric patients in St. Luke's Children's Hospital who were admitted with COVID. And the range of those is more in the adolescent range from 11 to 17. Yeah, so that's for COVID admissions, that's the case. Now we're seeing a surge in our usual pediatric cases that require hospitalization, whether it's other respiratory illnesses or diseases. RSV, respiratory syncytial virus, is a common respiratory illness that results in hospitalization of younger children, and we're seeing some hospitalizations of children with that. That's not uncommon this time of year. And then the usual other stuff that causes kids to get hospitalized has continued. This is a time when we start seeing that increase in the usual hospitalizations, and that has the risk to put us under some additional stress and strain. I think it was yesterday we had 10 patients in our pediatric intensive care unit. Those are not patients with COVID. That's the range of kids in the pediatric intensive care unit. We're concerned. We're being mindful and preparing. If we see an increase in COVID patients that further stresses that, we need to be prepared, and I think we are.
Thank you. And then Ian Stevenson, you have an additional question. Please go ahead.
Thanks. Dr. Johnson, before when you were talking about how if this surge continues that your providers may start needing to make decisions about who receives care and who does not. And you said that your hospital has some processes in place to sort of figure that out. Is there anything you can say about what those processes are and how those decisions would be made?
Yeah, we align with the state's crisis standards of care guideline, which are available on the Department of Health and Welfare website. We follow those for the most part. There might be some slight nuances to address some of the unique situations within a big health system like the one that we have, but it for the most part follows those state guidelines. The principles of crisis standards of care are that you use equitable distribution of resources. So you avoid bias, you try to make sure that the decisions that are made are not impacted by other factors beyond a person's health and wellness and their chance of recovery. And then you use the principle that you'll use your limited resources to save the most lives possible with those limited resources, and do that in an equitable way. Those are the general principles. I would refer you to that Department of Health and Welfare crisis standards of care document.
Okay, thank you. And I'm not sure if Rachel and Andrew, if you have additional questions or if those are residual hands. Rachel, do you have another question? If so, please do type it in the chat if you're still having some issues. And I'll also ask Andrew if he has a follow-up.
Yeah, quick follow-up. You mentioned there's a concern about the supply of monoclonal antibodies, and you are encouraging people, if they fit the criteria and the situation, to go and get that. But is there a concern, I guess, of there might be a timeline when they're not going to be available anymore because that supply is limited?
Right. Yeah, that definitely could happen. We are dependent on the federal government being able to provide the monoclonal antibody. And they're working on ramping up supply, but absolutely there's a chance we will not have enough monoclonal antibody. We already have put in a system where we are prioritizing making decisions on patients based on who is likely to get the most benefit from the monoclonal antibodies, and we are scheduling those patients first to make sure that we get those people who have the highest need. So, I think, again, as we think about the monoclonal antibodies, they are going to help that individual patient, but they're actually going to also help the hospital, because we know roughly for every 20 people who get the monoclonal antibody who are in that risk category, it can avoid one hospital admission. So again, this is another thing that we can do to try to take some of the pressure off of the hospital. One other thing on the monoclonal antibody, because we cannot take nurses out of the hospital to give monoclonal antibody, we have leveraged our pharmacies to do this, and the pharmacists do not put IVs in. That's not part of their scope of practice or their training. So our pharmacists here do it by subcutaneous injection. So it's kind of like an insulin injection, only it requires 4 separate injections to get enough volume in. So we have had some people being surprised when they show up and they're told they're going to need subcutaneous injections. But that right now is our that's not the case everywhere that we're giving it, but that is our most readily available way to get it into people.
Thank you, Dr. McGeorge. And I also understand that you've been able to treat quite a few people by doing that. So that's wonderful news. Okay, and then we also have a question from Karen Bosick at Ion Sun Valley. Karen, go ahead. And Karen, if you want to type your question into the chat, I'll be happy to read it as well. In the meantime, Dr. McGeorge, Dr. Johnson, do you have any closing remarks? I know we covered quite a bit.
Stay safe. I end every communication with people I care about. Take care of yourself. Hug your family. Appreciate the day. Stay safe. Give your support. Show your support of healthcare workers and other frontline workers. Everyone's doing their best under very tough circumstances.
Absolutely. Okay, and I do see that Ian has one more question. Ian, please go ahead.
Thanks. I really appreciate your time. Before, when you were talking about vaccines, you were talking about the different ones being potentially authorized at different points. I know there are some ongoing studies about the potential benefits of mixing different types of vaccines. Is there anything you can say about how far down the road that sort of authorization might be for people to receive different types?
Yeah, so when you say mixing, I think what you're talking about is really having a crossover. So first that vaccine might be Pfizer and then second Moderna, right, or vice versa, I think, right? So the messenger RNAs, those two vaccines, that has been looked at. I think, there was one study a while back that looked at that. And so it certainly is not generally recommended right now, certainly has not been studied enough. It is allowed in the situation of the immunocompromised that was released about 6 weeks ago, that if, again, we'll use the organ transplant example, if that person got 2 Modernas and now they can get a third vaccine at 4 weeks, and if they can't get a Moderna, they could get a Pfizer. So that's the only circumstance where today it's approved. But again, there are more studies that need to be done. And as you all know, we are really waiting for the ability to vaccinate children age 5 to 11 and expecting maybe, maybe 5 or 6 weeks to hopefully be able to have the ability to do that. And I think that's going to just be incredibly meaningful and so helpful in keeping our schools safe.
Well, thank you, everyone, for your time and for your engagement. And we look forward to our next connection. And of course, in the meantime, as our doctors have asked, please stay safe and thank a healthcare worker. All right. Thank you, everyone.
Thank you.